Now you can share your screen. No issues with that. Just click on share screen.
Now it's not possible. So we tried it before the session, but now it doesn't let me. So now it will work. Okay, see my screen? Yeah, great. So, thank you again. And well, I'm a radiation oncologist, so I'm really glad that there are a lot of cardiologists in the session. But of course, I can only report on the radiation oncology part, not on the cardiology part. And I will try to summarize the clinical indications and the problems of the target delineation for the cardiac radiosurgery. So as we already heard in the introduction, this is a new therapy option for patients who had no any other options for an invasive ablation of ventricular tachycardia. These are very, very sick patients, so a little bit similar to a palliative situation to the oncology. And we know from animal experiments and also previous a lot of works from Oliver Blanc and other groups that stereotactic radiotherapy can induce changes in this myocardial scar, which can then stop these arrhythmias. So it is quite the marriage of two fields of cardiology and stereotactic body radiation therapy, which has been improved in the last 10 to 15 years in the oligometastatic situation, or for example for stage 1 lung cancer. And from that field we have a lot of experience on technical workflows in this field. So there are now quite a lot of reviews from 2020 and 2021 regarding the series which have been published until now. So these are probably the four most important series of cardiac SBRT, the Washington University or Ostrava or Lausanne. They are all quite similar in number of patients, 10 to 19 patients in patient age. All of the patients had some kind of cardiopathy and left ventricular ejection fraction changes. And the treatment has been completed either on linear accelerator or CyberKnife systems with small PTV margins. And the PTVs were quite different in all of these series. The dose was between 22 and 25 gray in one fraction, and the toxicity was acceptable, mild, and all series have reduced the VT burden. So here is, for example, one series from Ostrava, from Czechia, which has been published in 2019, where we see that the VT has been reduced after radiosurgery. So it was one of the first cases where we could see an efficacy, and the toxicity was quite low in this series. The most known paper or publication was from the Washington group, from Kupelich, in the New England Journal of Medicine, where the same results have been published. So the VT episodes could be reduced with cardiac radiosurgery, and they also published some histological changes after radiosurgery, and then follow-up CT imaging after 3 and 12 months, where we can see as an only small side effect radiation-induced pneumonitis, which is then disappearing after 12 months. We have the prospective data published by the Washington group, the Anchor VT trial. They included patients with more than 3 episodes of VT and with minimal one successful catheter ablation. Patients were excluded who had a very short life expectancy or polymorph VT or fibrillation. They apply 25 Gray, a small GTV, and a 4D CT and ITV concept, and ask after the efficacy, how many VT episodes can be detected, ICD shocks, and overall survival. They have shown 1 year overall survival of 72% and 3 deaths completely deaths. The toxicity was acceptable. However, they have seen some pericarditis, pericardiac effusions, and also pneumonitis, but the efficacy was quite good, so the VT episodes could be reduced after stereotactic radiosurgery. So their coronavirus just stopped us a little bit. So this slide is from Boris Rudic, our cardiologist in Mannheim. So we did a PubMed search on SBRT or STAR treatments, and we see that there has been a little bit of probably due to coronavirus reduction of also of invasive ablations in 2020. So there is no talk without coronavirus this year, and this also we also felt it in the reputation of the radioablation trials. The patients' counts really went down last year. So, but if we look at all studies which have been published now, the clinical indications can be summarized for repeat VTs, which do not disappear despite of a maximal anti-arrhythmic therapy, and patients had at least one unsuccessful radiofrequency ablation in an experienced center, or they have contraindications for invasive ablation, for example, mechanical valves or intracardiac thrombi. The VT has to be documented in a 12-channel ECG, especially for large scars, and it has an electroanatomical mapping, invasive or non-invasive, has to be available. So this is the German trial designed by Dr. Blank, speaking after me. So it's a radiosurgery for ventricular tachycardia, preclinical and clinical evidence. The study design has been published last year. In this study, patients can be included whose life expectancy is at least 6 months, who have ICD, have a symptomatic monomorphic ventricular tachycardia, which require ICD interventions, and who are refractory to anti-arrhythmic medication in a maximal dose. And here the inclusion criteria, either VT recurrence with at least 3 episodes within 3 months, or the VT is inducible by ICD with a non-invasive program stimulation, or C, both. And the study is kind of safety trial. So the first patient will be enrolled, and then the follow-up is done very frequently, especially in the first half year. So we see the patients very frequently and monitor the side effects, the serious side effects. And the next patient can be included if there was no serious side effect in the last patients, and data safety monitoring board is just controlling the methods and the results. So now there is also a new European Union online platform. It's called StopStorm, where these cases can be collected, so that it's a standardized treatment and outcome platform in a framework of a multidisciplinary consortium. So the German study patients will be also part of this European database. So now it's probably more interesting how can we perform this therapy. So the first thing is that for the radiation oncologist, that the contouring of the organs at risk is a bit more complicated, as for example for a lung SBRT. So we have to learn more about the heart. And we have to learn to define the cardiac substructures and contour the cardiac substructures, all coronary arteries and the atria and ventricles and big vessels and also the heart of the left ventricle. So, for example, in the Stop-Stone Consortium, 4 hours are thought to be adequate for one case for contouring these substructures. And then we come to the most important question: how do we define the target of this ablation? And there are, of course, 2 parts of this. So it's a real interdisciplinary work with the cardiologists. So first, the cardiology colleagues really have to say where we should ablate. And if I understand well, as a radiation oncologist, there is also a discussion in the cardiology fields, what is the optimal target for the invasive ablation. So there is, for example, this study which compared in a randomized manner for patients in ischemic cardiomyopathy, if it's better to ablate the whole scar or if it's better to ablate the substrate only, and they received better results with substrate based ablation. So it's a discussion, and if we discuss with cardiologists, then we always have the feeling that that field is also an improvement in cardiology. So the first step is to define for SBRT the scar or border zone, and mostly the whole scar is too large to irradiate. So until now, in the published studies, the mean volume of the target volume was 70 cubic centimeters, but up to a maximum of almost 300 in the Robinson data. And they also have shown in the ASTRO last year that too large target volumes were associated with worse overall survival. So probably we have to reduce the target volume to a reasonable size to reduce also toxicity. So how can we define the targets? There are, of course, methods which are available in each country and which are absolutely necessary to be able to define the targets. So, for example, the 12-channel ECG and the electroanatomical mapping. However, there are additional radiological methods, so the cardiac CT, the cardiac MRI, PET CT, SPECT, or a special functional MRI imaging, which, if available, can be, of course, included to the target volume definition and can be helpful there. And then we have, of course, if we once defined this target volume and the electroanatomical mapping, and we really have the cardiological target, then we have to transfer it to the radiation oncologic planning CT. And this is a step which is still very hard to do, because we have a wish list, and it would be nice if we had it, but it's probably the work of the next few years to have this wish list. So we would like to integrate all imaging and functional modalities to the treatment planning system. We would need an optimal matching of all imaging modalities with the planning CTs. We need the same slice thicknesses and the orientation. So, for example, if I say a cardiologist, I have an axial slice, he understands something completely another thing as the radiological axial or transversal slices. Then we would need the same motion phase, and with that the same cardiac volume. So there are really many technical issues, which I think Oliver will also talk about in the next lecture. And what was the reality until now? So how have the target volumes have been designed in the studies until now? So our studies have 12-channel ECG and electroanatomic mapping data. The 3D imaging is mostly only CT. So, for example, in Germany, on this electroanatomical mapping, then some kind of contouring occurs, and then on the CT also cardiac substructures have to be contoured, and then this contour has to be somehow transferred to the CT, which has a completely different orientation. And it is really an intellectual process to do that transfer. You can use the help of the distance of surrogate structures, for example, valves or aorta or coronary arteries or the septum. And it's an interdisciplinary procedure together with a cardiologist and radiation oncologist and physicist. And of course, you can correlate it to the 17-segment model. And at the end, the consensus has to be found. So in the framework of the ENCORE VT study, they have used the 17-segment model more strongly, as we do in Europe. And in this year, also a Red Journal article has been published how these segments can be translated to a 3D CT anatomy. So if the cardiologists say, okay, just irradiate segment 5, then you can find segment 5 based on this atlas on your planning CT. This paper is from the group in Ostrava, and it's very interesting. It's just a case report, but they report stereotactic radiosurgery, which has had to be repeated in one patient. Because the first SBRT session failed. After the failed SBRT session, they subsequently remapped the patient and then they remapped the scar. And they think that the targeting was some kind of incorrect due to the integration of the data from the electroanatomical mapping system, and probably due to by a better target definition, probably the second SBRT session has not have been necessary. So it was also an alarming paper to tell how important the targeting is and how important it is to try to integrate the electroanatomic data in the planning system, probably automatically to avoid human errors. So we did a small contouring benchmarking for the Raventa trial. So we just took 3 in Germany and 1 in Switzerland treated cardiac SBRT cases with all data which were available. So the epicrisis of the patients and the ECGs and the electroanatomical mapping data and the imaging data. And we sent out these data for 5 centers and with all the information. And the task was for all interdisciplinary teams that they should contour the clinical target volume for an SBRT on the electroanatomic mapping screenshots, and they should generate a CTV on the planning CT. And then we received these structures back together with the planning CT. Afterwards, all cases were discussed. We tried to do a consensus finding, and we compared those structures. And for the first question was on the cardiologists, which were the most important information which they received retrospectively. And already here we could see that the cardiologists were really having different approaches. So some cardiologists told that for them it was absolutely the electroanatomical mapping which was the most important information for the decision. But some other cardiologists found the 12-lead ECG more important. If we looked at target localization anatomically or the segments the cardiologist wanted to target, that there was also a bit of differences between each centers. And there were also the structures which should be avoided during contouring. Some wanted to spare the coronary arteries or epicardial areas. So there were quite user-dependent differences already in the cardiologic decisions. And from that, it's, for example, a case that was the most concordant case, our third case, where I also presume that we had already a bit of learning effect or learning curve. Up there you see the contours and the electroanatomical mapping. So here we were quite fine, all 5 centers defined similar regions. However, we see differences in the size of the target volumes, and then all centers have to contour it in the CT. And here we see each with the different colors, the contours of the 5 different centers. And what you see, well, each center targeted almost the same region. However, there were substantial differences or some kind of visible differences, which can be seen the best on the 3D reconstruction, where, for example, a craniocaudal shift in the target volume can be observed between the different centers. So at the end, after really intensive discussions, we over all 3 cases tried to find a consensus structure, which has been selected as a fusion of the 2 most appropriate structures. And then we tried to put the differences of these structures in numbers. And this was based in just a structure analysis, which you can also read in a lot of radiation oncology papers where, for example, target volumes or any structures are compared. Basically, the volumes, the localizations, and other, for example, surface distance of the different structures and the DICE index has been compared. So if a structure is identical to the other, then it has a DICE index of 1, and if it's smaller than 1, it's some kind of differences. If we look at, for example, the third case, which was the most accurate or the most similar between the cases, we still see that the DICE indexes are in some centers more than 0.7, but however, there are some centers with so very bad similarity in these indexes. So I think the conclusion from this paper is that it's really hard to define a target volume, and there are a lot of things to discuss. And at least for the step of the transfer of the target volume from the electroanatomical mapping to the planning CT, we need an automatic tool to avoid the human error for the transfer. So that's what I wanted to show. There are some tools which have been already published for this purpose. So it's also another German group who published a slicer, which can load an electroanatomical map to a 3D slicer, and then it can be aligned with on the surface with a segmented left ventricle, and then the target volume can be then defined kind of automatically. And a software is being developed by Professor Speichert in Lübeck in Germany, working together with Oliver, also for the automatic registration. So you see here, this is a MATLAB-based software where you can see in red the contour of the left ventricle, and as a surrogate structure the aorta. And in blue, the electroanatomical mapping data, which can then be matched based on the anatomy. And then the target region can be transferred automatically. So we looked at our first case. We treated in Mannheim. So the cardiologist wanted to treat quite a large region in segment 4, imaged on this 17 segment model, and we did a planning CT in deep inspiration breath hold to reduce the breathing motion. We registered it deformably to the cardiac CT, which then ensured the easier contouring of the cardiac substructures. And then we received help in the transfer of the structures from the electroanatomic mapping. So this is, for example, a 2D transfer from the electroanatomic map screenshots on the CT, which is just a line which can then be from which you can create a 3D structure transmurally and manually transfer it to the CT. And this was the result. You can compare. We did first the structure with this intellectual manual transfer, and afterwards with this automatic transfer. And you see we were not that bad, but there are some small differences, especially here in the craniocaudal and left-right direction. So we then corrected our CTV. And there's also possible complete 3D, so mesh, based on the mesh data from the electroanatomic mapping, transfer of the target volume and the planning CT, which we again compared the 2D transfer versus the 3D transfer. So this patient then was irradiated basically based on this target volume, which we created by this automatic transfer. We used just a BMAT plan and home beam CT and imaging and treatment in deep inspiration breath hold. The treatment was quite long. The patient was lying on the table about 60 minutes due to the repeated breath hold needed, but he managed it fine. He is also fine now after now more than 2 months after treatment. He doesn't have any toxicity except a very small pneumonitis just adjacent to the PTV in the lung. But that will be probably also red gradient in the next CT. So that was our first case which we treated. And I just like to thank for the invitation again, and of course for the whole Praventa team, especially Oliver. And I think I will then pass it to Oliver and be ready then for the questions afterwards.
Thank you, Judith, for that wonderful talk. And before we take questions, I think we'll have the talk by Dr. Oliver Blank, and in fact, he has promised that he will be answering many of these questions, and then we can have the discussion at the end of his talk. So, Dr. Oliver Blank, please.
Yes, thank you very much. I hope you can hear me well. Perfect. All right. Let me look here. All right. Let me give you some physics perspective of the treatment that we're discussing today, which is very exciting and has a very long history. And this was actually the initial idea came from Tom Fogarty, who's the inventor of many catheters. In 2001, actually, for the treatment of atrial fibrillation, and in 2006, the company CyberHeart was created, and we initially evaluated basically atrial fibrillation in animal models at the time, and this is me discussing with Tom Fogarty back then, what we want to target and how we approach this method. That was very exciting times back in 2008. So unfortunately, we ran out of money. We kind of burned about 16 million just on animal studies. That was very exciting on the research level, but not much on the venture capital level. And finally, the company and all its patents were bought by Varian in 2018. So my disclosures, basically, I've been an employee of CyberHeart from 2008 to 2010, but otherwise I have no disclosures. So you had already pinched this. We published a review of the technology and procedures and future opportunities on STAR. And basically what we have initially, we have electrophysiology information from various systems, Cardio or Navex or Cardio Insight. There's a lot of systems that can be used here. And additionally, you might use PET scans or MR, for anatomical scar imaging, and combine everything basically to generate the target structure. Well, I'll show you that in a little bit more detail. Then you have the motion analysis, and it becomes very tricky for radiotherapy because you have cardiac motion and respiratory motion on top of each other, so that's very tricky. We'll address that. You have your tools for motion management. Then you basically have your planning imaging that you know from stereotactic body radiotherapy. You have your PTV expansion, you have your prescription, and I will also show you about the dose and what it's like. And then you have your treatment planning, patient-specific QA, patient positioning, treatment localization, and dose delivery. So the lower parts are actually fairly straightforward and the same as you would do a long SBRT case. So let's have a look at the dose response relationship first, then we go into some target definition, motion management, treatment planning, and some treatment examples. So when we talk about the early works from CyberHeart, sometimes they publish 25 gray works and 25 gray does not work. So basically, from all the experiments that we did in the last 15 years, we can pretty much conclude that everything below 30 gray will not create a scar, and everything above 30 gray is single fraction. Multiple fractions hasn't been tried. So a single fraction of 35 gray will lead to fibrotic lesions in the heart. And you can treat block of electrical signals with that. So you see here an electrical block at the isthmus on the right atrium, and again here you see actually on the right side the cardiac mass for it. So that was very early. We treated everything from AV node to the left ventricle, to the left atrium, right atrium. We treated everything just to test out what's possible. Back then, after 2010, I went back to Germany to continue my research on an animal study, and we did basically a response study here. Treatment planning on the same day. It's an 8-hour procedure, basically with the LINAC treatment, standard LINAC treatment, and then we had 6 months later on the follow-up on various dose levels from 15 to basically 40 gray and 2.5 gray steps, and we just wanted to see what the effects are, and let me show you. And that has been reproduced now in the last years also. So we have 25 gray single fraction, doesn't do much. Also on the cardiology side, on the electrical side, there's not much damage that you can see here. With 32.5 gray, you see some scarring here denoted in gray and red, but no transmural scar that you can see. But with 40 gray, you see very nice transmural scarring and fibrosis after 6 months of treatment. So we have established a pathology for STAR, and we can see here a very nice block in the right superior pulmonary vein of the animal model. Here, pink model. And here you have some basically histology slides. So this is a regular structure. This is some mild fibrosis, and this is 25 gray. And note that most of the treatments for VT have been done with 25 gray. So you see only some mild fibrosis with 25 gray. You see some intermediate and moderate fibrosis on 30 gray here denoted in blue. And then with 32.5 gray, you see a larger fibrosis, and with 40 gray, you see basically a complete stenosis after 6 months. So, complete fibrosis, and even with stenosis in the vein. So that's what we don't want, of course. So we did all the analysis, and you can pretty much say that you need about 30 gray to get or more than 30 gray to get real fibrosis. But the question is, do you need fibrosis? That's very important. Or are there any other effects also? And we published that already in 2013 and 14. And the same was noted with not with just photons, so we did 6 induced photons. The same it was noted with protons or heavy ions. But basically the same dose response. And very nicely, a group from Korea has just published, with 35 gray, or 32.5 gray actually, a very nice block here for atrial fibrillation, pulmonary vein isolation model with the dose that we suggested would be useful, and they really reproduced that on an anterior, posterior lesion set. So you can really create a lesion with that dose. Now the question is, and we all know these publications in the New England Journal with only 5 patients, that was very exciting back in 2018. So why did 25 gray work? With a significant reduction in VT episodes, a number of ICDs shock 0 and even down to 0 in these 5 patients, and the pacing from the ICD even went to 0 in very short time. But they treated only 25 grams, so no fibrosis that they created. So we know fibrosis with doses over 30 gray, and there was this really nice group in Korea that published that, and you did also pinch that earlier. So basically we have swelling here, we have vocalization from intermediate doses between 20 and 30 gray basically. So we have this swelling, and basically this might be the case that in a damaged heart you can see immediate effect. Actually, there's reports on effects on the same day, which is, for radiation oncology very, very strange to see a same day effect. But these mechanisms that they published basically seem to be the key effect of the 25 gray delivery. So a functional dose that we see here. And this is very important to understand also for the long-term effects, because in some series we now see some late recurrences after 25 gray because of the lack of creating a scar with less than 30 gray. Okay, now we have kind of established that, and we're still in the process. This paper was just published 2 months ago, so we are very, very early in the stages of understanding the real mechanisms of what we actually do there, which is kind of interesting. We are 15 years out on research, and we have not really understood the mechanisms of what we actually do, which is kind of interesting. So, let's go to target definition. Judith has shown quite a number already. So for atrial fibrillation, we want to isolate the pulmonary veins, which is here, basically these 2 targets, or we can actually isolate the whole atrium as well, which has been done in a couple of patients. Actually, there have been 5 patients worldwide treated only for atrial fibrillation. So this is how it looks like. So you can either do like an anterior lesion set or like a pulmonary vein lesion set, but you can also see here the esophagus in the middle and the bronchial tree, which is really a tricky target for that kind of procedure. And remember, you really need to have higher doses than 30 gray here to create a block. So this is really what we went for with CyberHeart back in the days. And VT was not really our main interest because the money, as you say, it was a venture capital company in California, CyberHeart, and we were really into atrial fibrillation. But it has turned out that, for VT, it's much better use, and the patients will benefit much better from that. So let's have a look at target definition for VT, and you have presented that already. There's different ideas on, locating the clinical VT of treating basically the whole substrate. And there was some question in the chat, of treating the border zones and such. So that's very unknown. And if you present that idea, or like a map, electrophysiology map, with 5 different cardiologists, they will treat 5 different things, which is really interesting to see, and makes it really hard to reproduce. As you can see here in our paper, we show that very clearly. And even in the guidelines that have been published, it's really not clear what is the goal, what you should treat, which is really tricky to understand, and we're really at the beginning to understand that. There's some help which you can do. The 17-segment model that Judith has presented, there's software now that can basically map that to a contrast CT, which really helps you narrowing down what you want to treat. But in the end, your target might be a little bit larger than you think it is, and including motion and everything. So we're really treating a lot of cardiac tissue, which is scary, but it works, interestingly, and the toxicity is not very high. So there are some other workflows that have been published, and you would show that already, with integrating the cardiac system, so Cardio or Navex or Rhythmia maps, or even Cardio Insight onto the planning CT, which is the ultimate thing you want to do. We want to see basically the cardiology information here. But also, about deformable image registration, we're not even there yet. We really try to only import the data first to these systems. They're very incompatible. Cardiology and radiation oncology have not talked to each other ever. They're only starting to understand, okay, so we think we need to do something here. But in the next 5 to 10 years, that will be really interesting to see this integrating in the treatment planning systems that we have. So now coming to motion management, after we defined the target, it was some magic and some software that is out there these days, and really you need to sit down, the cardiologist, the radiation oncologist, and the medical physicist needs to sit down and understand what they want to treat, how it's mapped into the different systems, and really you need to have a lot of time of going through these systems and mechanisms that have been also published. So motion management for the STAR is pretty similar to actually motion management in SPRT. And we published last year. We published our technology quality requirements, and we stated basically that you need to do some systematic assessment and consistent consideration of periodic and non-periodic target motion during basically everything from imaging to target volume definition, dose simulation, everything. And there's certain techniques that you can use, like breath hold, free breathing with gated beam delivery, free breathing with continuous beam delivery using an ITV approach, mid-ventilation concept, or free breathing with dynamic tumor tracking. So these are all well known with all different systems that are out there. And what we actually only add, and this is again our cardiac review paper on the technical side, what you add is a cardiac motion component on top of the respiratory motion component, which you cannot compensate, not yet. Or maybe you can. There's even some discussion about that, and I will show you in a minute. So basically, you have some breath hold techniques, you have some gated delivery techniques on the respiratory side, and then you need to address the cardiac motion, basically tracking the cardiac motion, which is not possible yet, rather an ITV approach, compensating the cardiac motion. Or in combined ITV approach, or direct tracking plus ITV approach, or complete direct tracking, which is kind of the ultimate goal we all want to go to, but that will take a number of years to actually do that. However, let's have a look at the motion first. So for atrial fibrillation, we have some motion in the range of 5 millimeters in different directions. So that has been, published in a couple of papers now. So we only see 5 millimeter motion. Okay, so 5 millimeter, maybe it's not that much. And if we look at ventricular tachycardia motion, and this has been published by a group from Cleveland, they also only find like 2 to 3 to 4 millimeter motion. And remember, these patients are really they had a scar tissue in the heart, so basically an infarct, and this this infarct zone that we're treating is actually not moving much with cardiac motion due to the infarct. There's not really much live tissue there. So overall, we see again 5 millimeter motion. So the question is, and then they concluded that like 90% of the cases they looked at are less than 5 millimeter motion. So for respiratory motion, we see quite a difference. There's about a centimeter, and especially if you don't do motion compression with an abdominal compression, if you do free breathing, you see even up to 2 centimeter motion. So you really need to address the respiratory motion, but do you need to address the cardiac motion? That's the big question. And we've done some studies back in the days. So this is the concept that we did initially, like tracking the respiratory motion, compensating the cardiac motion with an ITV envelope, creating a margin. But what we did is we tested that in phantoms. And we found out, so this is basically the dose curve that you see here in the target area when you don't compensate anything. So you see like a significant drop, and this is when you don't compensate only the cardiac motion. It doesn't look really different because what we need, or what we saw here in various experiments, is that when you have cardiac motion of less than 1 centimeter, the dosimetry effects are pretty much zero or not negligible. So 1 centimeter motion, which we hardly see in the targets that we treat, will create only minor effects on the dose side, which is really interesting because you have these fast pulsating motion, and when you treat that, really the dosimetry effects are really low. So maybe we don't really need to take care of that cardiac motion. Maybe we don't really need to be scared of that. And we have shown it in numerous publications now on the phantom studies. So how can we track the respiratory motion? We have basically, in the CyberKnife, and there was some question in the chat, most patients have an ICD implanted, and the ICD tips that are screwed into the ventricle or in the coronary sinus or wherever they are, you can track those electrodes. We did numerous testings back in 2008 on various catheter tips and pacemaker lead tips and everything. And the CyberKnife system actually works pretty well on this. And the group in Ostrava, they treated about 30 patients by now, all treating with the CyberKnife and all tracking these electrodes, which is really, really nice and gives you nice feedback. And also when you do Linac-based treatments, this is the group from St. Louis, they have checked their motion, actually cardiac motion and respiratory motion, you see is not really that high. And they compared the motion between abdominal compression and free breathing ITV approaches in their patients. And you see the difference is really not high. So they see motion only of 5 millimeters, respiratory motion, and either with free breathing or with abdominal compression. And they could really also use, with this Combeam CT, they use the leads as well, the ICD leads for registration during treatment. And this is really interesting because we might actually not be really scared at all about that motion we have. Of course, there are patients that will move quite a bit, but most of the patients, when you do a very good setup as you do on lung SBRT, you will be able to treat these patients also for STAR. But of course, we can go one step further, and this is more into research now. We can do 5D dose calculation. So not only just looking into 4D of integrating the respiratory motion component, but also integrating the cardiac motion component. And this is what we did in our animal studies back in 2014. So basically, the black line is the original planet dose, and here you see only the cardiac motion component is very small that you see here really. When you reduce that basically for the cardiac dose calculation, then for the respiratory dose calculation, this is the lower motion here in these animals. And when you combine the two, then you get the realistic dose calculation, which is really nice. But again, the cardiac motion itself is not really the biggest issue that we have seen here. And if you have a good dose, motion compensation for respiratory motion, you will be able to treat those. Now, can we do everything? Can we track even the cardiac motion? Yeah, we can. There's a group in Vancouver that did that. They actually gated the beam for the respiratory, for the cardiac signal, including the respiratory signal. And so if you're interested, I can refer you to that paper from Justin Poon. And they even demonstrated that they can treat it statically and with a gated delivery based on the cardiac ECG signal. So that's really interesting, but the question is, do we really need that? So I'm not 100% sure we do. It's nice if it works in the future, but I don't think we really do. I think we treat most of our cases are really low motion there on the cardiac side. So going forward to treatment planning, there's a lot of dose limits that have been published, and also within our Reventa trial, we have published these dose limits. And it took a long time with our authorities also to go over them and to check. And mostly the biggest problem is we don't know about internal cardiac structures or substructures. So we can really only give some of those recommendations. Some limitations for the coronary arteries, which is a bit sketchy. So these are sometimes in the target or near the target. So, you know, there is some variability that we still have to learn on the coronary arteries, what dose we can give. The order is pretty straightforward, as we know the dose limits there from the lung SBRT, but also nicely, and I can only refer to the Knudsen paper, is a subgroup or is a sub-analysis of the dosimetric analysis of cardiac structures from their clinical trial patients, which is 19 patients. For STAR. So they really have evaluated that, and I think we will learn a lot more on cardiac substructures in the future. But otherwise, we can only do recommendations other than the coronaries, which is still a little bit in limbo, as I said. Now, externally, it's pretty straightforward. There's a lot of data out there that we know from single fraction treatments. And actually, these are for VT patients that's mostly far away, but some cases are near the stomach. So we have to be careful there. And for ICDs, well, so the electrodes are fine. There are not really any issues with treating the electrodes with those. But the electronics in the chest that you have to block basically with radiation. You should really make sure that below 0.5 gray is received by the major electronics there on the chest. And there's a nice report of the APM TG203 about that dose and management of these patients. And that's also the reason we only treat with 6 MV, because if you go higher, you may get interference between the ICDs and basically the linear accelerators and the system. So we really try to keep them at 6 MV. For our Reventa trial, we only allow 6 MV treatment, and with that, you're actually pretty fine. So, treatment plan for AFib, we've published a number of patients, a number of publications now, and really for atrial fibrillation, it's really tricky to treat that with 30 gray or higher right next to the esophagus. This is really something that is probably not going to be a very safe procedure in the future or effective. There are some treatments, but the results are very limited. So it has been proven as very risky, very tricky to treat. We have published that, also trying to look at MRI Linacs or at protons, at heavy ions. That might be some future, but really I don't see that treatment being mainstream in the near future, because of that problem that we really need to have 30 gray to block the electrical signals. And what we don't need to do in ventricular tachycardia. This is some work. So we had numerous, treatment planning benchmarks, and really we came to the same conclusion that every system today can treat everything. So there's some benefit of CyberKnife versus Linac-based or VMAT-based systems, but really in the end they can all do the same if you have a good user. And we've seen the same basically here, some 3 VMAT cases and 3 CyberKnife cases. So there's some good CyberKnife cases, some good VMAT cases for VT that you can use, but again, it depends all on the user, and the systems can create the same dose as you can see here, like in case 3, the Riva, here or the aorta, or even here the left ventricle or right ventricle dose. you get all pretty much the same doses with all systems that you can use. So really, from the treatment planning perspective, you have your dose limits. You want to have 25 gray. You maybe want to have some inhomogeneity in your target, which is unclear. Do you want to treat 25 gray 80% isodose, or maybe go lower and have some more high dose in the real target to create long-term scar? That is really unclear. We don't know. We're at the beginning there. But otherwise, it's pretty straightforward and pretty much the same as you do in lung SBRT. Can you do protons? Yes, there are some studies with protons, and protons do better. Maybe it's basically the same question that we have for any other indication at the moment. And of course, this will be investigated, and we will see where that leads. So coming to treatment, just give you some examples, and this is again from our review, and I really encourage you to read that. So there have been treatments with CyberKnife, all 25 gray in single fraction. They did all basically fiducial tracking with an ICD, so that works pretty well. And some used, an ITV-based motion management on the cardiac side on top. And otherwise just a simple CyberKnife system. But you see on the treatment times, 90 minutes, 120 minutes, there is some reports that delivering 25 gray in 90 minutes is something very different than 25 gray in 10 minutes, which is possible with linear accelerators, with Xeon linear accelerators, which we see here. There's a lot more treatments done, also 25 gray in single fraction mostly. And there's some treatment planning margins, ITV approaches, some motion compression, but mostly ITV and motion compression wherever possible. So no dating, no tracking, nothing like that, what we find in the literature. But very fast treatments, 4 minutes, 5 minutes, 14 minutes. And maybe that's also the reason why we see some differences between CyberKnife and between standard LINAC efficacy. So we really see some difference there, but we need more data to be conclusive. I personally think that with the accuracy you have on the CyberKnife, you will lose with the treatment time, and then you lose efficacy, because we're not treating tumor, we're treating basically healthy cardiac tissue, which will heal during that process. And we know from Jack Fowler, which we talked a lot to back then, that treatment of 90 minutes is very different than a treatment of 4 or 5 minutes. So here's some examples. So CyberKnife, this was a case that we treated and in our center in Germany, a patient with an aneurysm here on the lower part, and we really wanted to have the accuracy, because right below, you can see that here in the lower corner, is the stomach, so we really, really wanted to have a good treatment accuracy here. But the treatment, again, as I said, took 90 minutes. Here you see the tip of the catheter. Actually, we have some motion that you can see around, unfortunately, some motion blurring, and a second tip. But using the tip for treatment was very easy to do. You have this motion modeling here. You see some errors in the motion modeling. Why is that? Because you see the cardiac component on top as correlation error. The CyberKnife system can only compensate the respiratory motion, and the correlation error that you see here is basically the cardiac component. But the treatment accuracy is still below 3 millimeter, which is really nice. However, again, long treatment. And these are just some examples. This is the guy with the big heart, this is a cardiologist, the therapist beaming, the radiation oncologist is basically down here. This is Professor Schweikart, who's one of the initial inventors of the CyberKnife. And this is our first CyberKnife treatment in Germany on VT. We also did that with TrueBeam. A very fragile patient could not lay down more than 30 minutes, so not possible CyberKnife. We did an ITV concept based on 4D CT, a 5 millimeter margin. We also included an ITV, somewhat a small ITV for the cardiac motion. We did 4 dynamic conformal arcs, very fast treatment, and in between 2 arcs, we did basically we did another CVCT for setup. And this is the patient here. And you see. We have ECG monitoring during treatment, and we check basically the collision here, and then we treat in 10 minutes from start alignment to basically finish of the treatment. And here you see not Corona, before Corona, of course. Here you see the team that's needed for treatment, and we have many physicists here, we have many clinicians here, therapists, and the boss on the left-hand side, and the cardiologist. We have 2 cardiologists on standby should anything happen to the patient during treatment. So that's really important to have a cardiologist on standby as well during treatment and doing the ECG monitoring in room. And this is another example of it. I'm sorry that this was performed by the best deep inspiration breath work team in the world. This was done by Judith in Mannheim using the Versa HD and deep inspiration breath work and Catalyst with gating. We're very ambitious, very precise treatment that we published together. Also, that the precision is very similar to Cyberknife. So this can be also done if you have a great team and doing the setup. So you did very here a compliment to this. I think could be actually the first in the world that has been performed this way. And then we have this has been published from the Zurich group. They also treated on an MR Linac. They did extensive testing at the beginning. I'm not really happy to have patients with pacemaker, and this case was actually with a pacemaker that was not allowed, was not MR usable. So they really treated this patient with ICD off. We generally treat with ICD on during treatment, so that's very tricky. And they treated not the heart, but they treated a substructure here. Very ambitious, but successful treatment. Very nice that they did. And last example, they treated with protons here in Italy. That was recently published by this group, and so you can do it too. And there's actually been 1 or 2 patients being treated with heavy ions in Heidelberg now. So every system can be used. You shouldn't be scared. Should you do it for all cases? Probably not, but it's very interesting that you can basically use every system that's out there. So we still have a lot to do, and as Judith said, there's StopStorm. And in StopStorm, we're trying to come up with a certain way of harmonizing this treatment, which is really, really tricky to do, especially on the target definition side. And then we're trying to have build up a registry in Europe, but it's not limited to Europe, which is really nice. So we can also include centers from around the world, for example, India, which is really a really nice thing. And we can register all cases in this database and then evaluate that jointly with the metrics that we set up. So, and it will come along with benchmarks, with the quality criteria that we happily give also to new centers to help them along to get started at the start. Thank you very much.